two techniques in mind. We wanted to compare the functional outcome and or the clinical and radiological outcomes of these two techniques on patients undergoing total knee arthroplasty in Pakistan in our setups. A lot of work has not yet been done on this topic. So that was the reason what drew me towards this. And like it's the first study of its kind being done on Pakistani population. We have some foreign studies, but there is no study being done yet on Pakistani population. So we hope that our findings may make a difference, or we may set some sort of standard guidelines which may guide us towards telling which sort of resection technique is better. So I'm the principal author or the main corresponding author conducting this research. And my co-author was Professor Muhammad Umar Saab, who needs no introduction. He's a masterclass surgeon. He's a teacher of teachers, diploma at American Board, and remained head of orthopedic department for around 20 to 25 years. So the other surgeon was the other person was Dr. Imamuddin, who is a consultant orthopedic surgeon and Institute of Orthopedics and Surgery, Karachi. And Dr. Azhar Rashid is also doing fellowship in joint replacement and adult reconstruction at the same institute. Dr. Asadullah Mahmood is a senior registrar at Nistar Hospital, and Dr. Mohammad Umair is a consultant orthopedic surgeon at DHQ Hospital, Sahiwal. If you could just excuse me just for a minute, I may lock the door. Sorry, in fact. Although patellar resection techniques, although the resurfacing of the patella was a bit controversial initially, considering the fact that people had different opinion whether to resurface the patella or not. But later on, that patellar resurfacing has become a standard technique in doing total knee arthroplasty, and most of the orthopedic surgeons do patellar resection. The point was whether to resurface the patella or not depends upon its indication and whether it's done well or not. By done well, we mean if the patella is resurfaced in a good way and there is a symmetrical resurfacing of the patella, then patellar resurfacing has far better results than the unresurfaced patellae. So keeping that in mind, we wanted to analyze the results of these two different techniques. Symmetric resurfacing of patella means that the resection plane of the patella must be parallel to the anterior surface of the patella. If it's parallel, then we can say that the patella resurfaced is symmetrical one. And if it's unparalleled, then obviously it's an unsymmetric one and asymmetric one. And asymmetric resection of the patella may lead to multiple patellofemoral problems, as well as patellofemoral instability, as well as different sort of radiological abnormalities or problems, as well as anterior knee pain to the patient. Even in the expert hands, there is a 10% risk of asymmetric resurfacing of the patella. So for symmetric resurfacing of the patella, the two techniques that are considered in this topic, they have some sort of differences. What we felt during our patients being operated at the Institute of Orthopedics and Surgery, Karachi. First difference was that in freehand resection, there is a support anteriorly. We can hold the patella with reduction clamps, as well as we can put a finger beneath the anterior surface of the patella, and we can have a smooth cut. In the jigs, there is no anterior contact point of the jig with the anterior surface of the patella, basically. So the jig may just tilt, and the patella may tilt within the jig, and it may have a low or high surface point, and obviously the cut may be made asymmetrically. Secondly, with the freehand resection technique, we may have an eyeballing sort of technique, like we can continuously check and balance that our patella being resurfaced is is resurfaced symmetrically. There are no bumps or there is no asymmetric cutting of the patella. We can continuously check and balance, and likewise, we can then manipulate it accordingly. While in jig technique, we can't manipulate it. Like the jig is placed once and we can't like alter it now. So we can continuously have a check and balance by eyeballing method. Third difference is that we may also have a haptic sort of feedback mechanism. Haptic feedback mechanism means that it's basically a blind sort of mechanism. That's what it came into being. That it's a blind technique. We can just feel the patella at different points, and we can assess whether the symmetry, whether the thickness of the patella is symmetric or not at different points. And thus we can have an idea that we are going well. And if there is some difference or asymmetry, we can just then readjust our plane of cutting, which is done by freehand. While in jig, this is also not possible. Haptic feedback mechanism is also not possible in jig. And lastly, in the freehand technique, we can have multiple resections until we get a symmetrically resurfaced patella, and we can measure the thickness. In jig, we cannot have repeated resections until we just reapply the jig again, and then we can have a cut again. So we can't continuously like check and balance or continuously monitor it accordingly. So with these facts in mind, we decided that we must have some sort of, we hypothesized that the freehand technique should have better results in terms of clinical and radiological outcomes as compared to the cutting guide technique. So just let me show you some introduction. Just I want to go back on this slide actually, somewhat. Yeah, just a minute. So our hypothesis was made on this, and the clinical radiological parameters which we assessed were actually the clinical parameters were patellar glide test and patellar grind test, as well as patellar edge tenderness and the anterior knee pain. And the radiological parameters were lateral patellar tilt and the lateral patellar displacement. We measured the clinical and radiological parameters at our follow-up visits of the patient, which were planned at around second week postoperatively, fourth week postoperatively, and then monthly for the next 5 months. So a total of 6 months follow-up was planned for the patients, and on each follow-up, we had designed a performer, which we filled up on each follow-up of the patient. Like we categorically filled the clinical as well as radiological parameters at each follow-up visit of the patient to have a continuous like feedback. So the sample selection criteria that we used was that we had an inclusion criteria that patients with either gender or age were included with primary osteoarthritis of the knee, at least having grade 2 or more according to the Hellbeck classification. And they had a failed conservative management for at least 3 months. The other inclusion criteria was that they had a varus less than 20 degrees and valgus less than 15 degrees. The exclusion criteria were simple, that that any criteria which may hamper our results, we excluded that, like sort of previous knee surgery, patella alta, patellar fracture previously, inflammatory arthritis, patellofemoral instabilities, flexion contractures, or restricted range of motion around knee joint. So the surgical technique we used, that all the patients were given either general or spinal or epidural anesthesia as per their clinical or comorbidities. The patient positioning was supine in all the cases. Tourniquet was applied in all the cases. Drapes or conventional drapes were used, and afterwards, additionally, surgical disposable drapes was also used over them. Surgical technique, we followed the same surgical technique in all the patients. That was a subvastus approach, cordyceps sparing approach. The same surgical team operated upon all the patients. There were no other surgeons. Like the same team was there on each and every patient. And the same implant was also used on each and every patient, which was by Zimmer Next Gen Legacy, so that our results may not alter by these sort of variables. The skin We followed the surgical technique. I would like to elaborate a bit the freehand patellar resection, like I elaborated a bit. We inverted the patella with the freehand technique, hold it with clips. We measured the pre-cut patellar thickness with a vernier caliper, and after cut we also measured the thickness. We used a standard 7.5 millimeter patellar thickness implant in all the cases, and we like cut infrasuperiorly in all the cases. With the freehand resection technique, we use eyeballing as well as haptic feedback mechanism. While in jigs, we could not alter much, but we tried to apply the jig as accurately as possible. Afterwards, like the other knee joint, like femoral and tibial components, were done already, and then the closure was done, and skin knee mobilizer was applied to the patients. Like I already described, that we followed up the patients immediately post-op at 2 weeks, 4 weeks, and then every monthly for the next 5 months, to a total of 6 months. So one thing that we actually missed, that the study design. The study design was I missed that, so I'm now coming back to it. Our study design was randomized controlled trial. It was conducted at Institute of Orthopedics and Surgery, Karachi. All the cases were done there. Study duration was exactly 6 months, from 1st Feb 2020 to 1st July 2020. We randomized or allocated the patients by the simple lottery method. We enrolled, we did it on a total of 114 patients. 57 patients were in each group. Group A was freehand section technique group, and group B was patellar section technique group. The data was collected, as I previously mentioned. The data was analyzed by SPSS version 22, and ethical approval was sought by the ethical review committee of the hospital. So now coming to the results. Of the total 114 patients, 39.5% were male and 60.5% were female patients. In freehand group, females were a bit lesser, 57.8, as compared to the other group, in which there was 63.2% females. Mean age of our patients was around 56 years, plus minus 6 years. Almost mean age of the patients in freehand group was 57 plus minus 5.6 years, while in other group, cutting technique group was 57.6. Mean age of the male patients was 59, almost around, and versus female, which were 54. Diabetes was noted in 33.3%, and in the other group it was around 35.1%. Hypertension, there was also no significant difference in hypertension and mean body index. These are almost similar in both the groups. So the real results which we wanted to focus on were the clinical and radiological results. So at 6 months post-operative follow-up, when the follow-up was completed, the patellar glide test was painful. In 8.8% patients of the freehand technique, as well as versus 10.5% in the cutting edge group. Like in the freehand group, the patellar glide test incidence, painful incidence was a bit lower. The patellar grind test in freehand group as well as in the cutting technique group was similar. 3.5% patients had painful patellar grind test in both the groups. Patellar edge tenderness was painful. It was at a bit higher in the freehand group as compared to the cutting edge group. This was the only test which we concluded that had a bit higher results of in terms of pain, or that was a bit more positive in the freehand group. Anterior knee pain in freehand group was a bit lower as compared to the cutting edge group. It was 5.3 against 8.8%. Lateral patellar tilt was also slightly lower in the freehand group as compared to the cutting edge group. And likewise, lateral patellar displacement was also slightly lower in the freehand group as compared to the cutting edge group. So all the parameters were more or less slightly lower in the freehand group as compared to the cutting edge group, except the patellar grind test, except the patellar edge tenderness test, which was a bit higher in the freehand group. The p-value of these tests was obviously greater than 0.05. So the results were statistically not very significant. They were a bit comparative sort of results. There was no greater statistical difference between these two. So yeah, there was no statistical difference in either gender side, obesity, diabetes, and hypertension. All the patients completed their follow-ups. There was no revision or no major complication that we encountered during this. So there were almost similar clinical and radiological results, which were achieved by both the techniques. But we differed in sort that previously we felt that according to studies, the patellar resection technique was a bit favored one technique, that it gave better results, clinical as well as radiological, as compared to the freehand section technique. But in our study, there was no such thing. Rather, slightly superior results were achieved by freehand dissection technique, although they were not statistically very significant. Postoperatively, slightly lesser frequency of patients had positive patellar glide test, patellar edge tenderness, and anterior knee pain in group A, that is freehand group, than in group B. P-value is obviously greater. No statistically significant difference in the values of mean values of lateral patellar tilt, lateral patellar displacement, and their outliers in both groups are noted. Kemp and Martin basically had similar sort of results like ours. They compared freehand technique versus cutting eye technique. They treated 90 patients with these techniques, and noticed that freehand technique resulted in relatively more accurate and results, and desired patellar thickness was also achieved better in the freehand group as compared to the other group. But Yuan basically differed from our study. According to his study, patellar resection technique was the better one as compared to the freehand technique. Lateral patellar tilt was lesser in the cutting eye technique, according to him, and the other variables were also better in the cutting eye technique, according to him. So anterior knee pain was also less in his study, unlike ours. So Yon was of the opinion that age, gender, height, weight, BMI, and the other range of motion had basically no influence on the anterior knee pain. So we concluded that freehand patellar resection technique, however, had slightly lower incidence of positive patellofemoral tests, that is patellar edge tenderness and the other tests that I mentioned previously, and slightly lower incidence of anterior knee pain than cutting eye technique. But this difference is basically not statistically significant. This is not a major sort of difference, and radiological outcome was also slightly better in freehand section technique. The limitations, obviously, there were limitations to the study. First of all, we had a smaller sample size. We need to have a larger sample size, and we had a shorter follow-up. We were not able to document the patient satisfaction. We were not able to estimate the predictors of anterior knee pain. There were also other predictors of anterior knee pain, like, for example, the composition of the components, different components that we use. We also could not evaluate the functional scores of knee in both the groups. This was a limitation, like other studies have some sort of knee scoring. So future recommendations was that we should look forward to have a larger sample, longer duration follow-up. The study should be conducted at multiple centers. We must also take into account the predictors of anterior knee pain, as well as the functional knee scoring should be done. There were no conflicts of interest, no funding was done, and these were the different references. I've almost concluded.
Yeah. Yes, thank you very much, Dr. Ahmed, for the very nice presentation. And now we will move to Dr. Mujahid Jameel. He's Assistant Professor of Orthopedics with his special interest in arthroplasty at Aga Khan University Hospital, Karachi. And he will do a commentary on your article. And then we will also have a question answer session. So I will request the participants to kindly put their questions in the chat box. So over to you, sir.
Assalamu alaikum, everybody. Can you hear me?
Ji sir, we can hear you.
Yes, sir.
So first of all, I want to congratulate Dr. Aisha. मैंने देखा है कि वो हर महीने, regardless of the beautiful or the whatever the circumstances are, she's here organizing this seminar, which is a wonderful effort and actually a very interesting and exciting effort, because we don't normally do this kind of evidence-based discussion, which is lacking in our teaching activities, even in big meetings. Usually we tend to have my experience, which is one way of sharing the learning process. But I think better is to have a more scientific and conclusive discussion rather than have a personal bias and experience. So पहली बात तो ये, very good, और special congratulations to the presenter as well. आपको पता ही है कि प्रेजेंटेशन बनाने के लिए आपको मेहनत करनी पड़ती है, और he has gone a long way to that. पहले उन्होंने स्टडी की, स्टडी कंडक्ट करके उसको समराइज किया, फिर पब्लिश कराया, और अब उसके बाद उसको प्रेजेंट भी कर रहे हैं. अच्छा, आपने कहा आर्टिकल पे कमेंट्री, तो मैं आई एम थिंकिंग दैट व्हाट वी शुड डू इज टू हैव द डिस्कशन इन टू पार्ट्स. One would be analysis of the article itself, and second would be to have some learning about this particular topic of patellar resection. So मैं अहमद से ये पूछना चाहता हूँ कि what are, according to him, what are the 3 best strengths of his study?
Sorry sir, I could not hear you actually.
मैं ये कह रहा हूँ कि आप आ रही है आवाज आपको?
जी सर, अब आ रही है.
So what I was saying is that we will have the discussion in 2 parts. First discussion would be about the study itself, and the second would be what we learn about patellar resection.
Okay, sir.
So the first part is the strengths and weaknesses of the study. So what do you think are the three strengths of your study?
Sir, like it was the first study of its kind, because what I saw that it wasn't done previously, at least here in our population. So yes, sir. The other strength was that it was basically supervised by the legendary Professor Muhammad Umar Saab, and basically I was continuously in touch with him, and I wanted to basically what I felt was that why freehand resection technique is not favored over the other techniques. So just I wanted to initiate this sort of study. That's why I selected the topic, because personally I felt that freehand section technique should be a better one, as we can have a continuous check and balance, like, and we have seen the patellar tilting in while jigs are applied, and I have seen asymmetric some sort of resurfacing. So I just it's not the strength maybe, but I just wanted to seek or peep into it.
Okay, third strength.
Third strength, I think there are only 2 strengths of my study. I'm unable to basically.
So that's fine. Let me tell you what I think.
Yes, sir.
So the first strength study, because we talk about scientific analysis, okay? So yes, the first strength of your study is that same team performed both the procedures.
Okay, sir.
What I mean to say is that if you had different teams performing different procedures, then results would be confounded. Okay, so sir, yes, the first most strength of your study is that the same team was involved in performing 2 different procedures, which kind of inherently takes away a lot of confounding factors. So that's one. Okay. Number 2 is I think you have got reasonable number on the topic that you have selected. So more than 25 on either side is a D number from the same institute within a period of 6 months. So that's another strength of your study. The third is good study design. So you kind of try to cover both the clinical and radiological features in a scientific way. So these are the three good strengths of your study. What are the weaknesses of your study, you think?
Sir, the first weakness was that we had not. First thing was that there was a shorter follow-up. It was a limited sort of study. That the follow-up was not too long, and the study period was also not too long. It was around 6 months. Secondly, the p-value was not that significant. Like the impact of this study may not be much because the p-value is not significant enough. So I hope that the p-value may be a bit significant. But I'm happy that at least it's comparative to the favored one technique, which I felt. And the third is that I did not include the knee scoring or functional knee scoring. Like the functional outcome was missing to some extent. We saw the clinical and radiological parameters, but the functional outcome of the patient, in fact, the final functional outcome was missing.
Okay, so I think, well, you may be right, but I would differ on those points. I think one weakness was that
Okay,
you had a very experienced surgeon on the side of your study. I know
okay,
Dr.
sir.
Umar, who has been there for quite some years, and I had the honor to be his resident as well in Aga Khan University Hospital. When I was a
Yes, sir.
resident, he was my main supervisor.
Yes, sir.
So his experience is unmatchable to any arthroplasty surgeon in Pakistan and
Yes, sir.
probably to many arthroplasty surgeons globally.
In the world. Yes,
So
sir.
once
Very,
you
very
have
right.
that kind of surgeon on one side, then your kind of design or your results are inherently biased, because I know Dr. Umar wants to do freehand technique as far as I know, and he loves to do that because he's
Yes,
beyond
sir.
the world of using this and that guide for total knee replacement surgery, especially patellar resection. So
Yes, sir.
that's one
Yes, sir.
kind of it's not in the negative sense, but it's in the sense of
Yeah.
pure scientific conclusions.
Yes, sir.
The
Yes, sir.
other weakness of your
Definitely.
study is that you included valgus knees as well. So you can't couple together varus and valgus knees for patellar resection technique outcomes, because every one of us knows that you would have a little bit of patellar subluxation always associated with valgus knees as compared to varus knees. So even if you have included, what I would have done is I would have assessed the outcome for valgus and varus knees separately rather than lumping them together.
Okay. Okay,
So
sir.
it's kind of a point that you could have made better in, because when you have made a lot of effort to do this study, right? It takes a
Yes, sir.
lot of effort to do a scientific study. So you
Yes,
could
sir.
have sort of increased the outcome or the look of your article by dividing the two knees separately
Okay.
for each group, and that would
Sure,
have
sir.
made it much more beautiful and meaningful to the audience and whoever read it. The third is,
Yes, sir.
you assess the clinical outcome by patellar grind test as well as anterior knee pain. So fine, fair enough, they are one of the parameters, but I think you could have made it more meaningful in terms of outcome by assessing by dynamic assessment of the symptoms for patellofemoral symptoms in particular. Everyone of us who does knee arthroplasty, or even if it does not do knee arthroplasty, knows that patellofemoral symptoms are peculiar symptoms that are present in certain activities of daily living as compared to medial knee symptoms and lateral knee symptoms. So if you could have in some way assessed in detail patellofemoral symptoms at least at 6 months follow-up, it would have been very decent, because by 6 months, most of the knee pain and other issues have gone, and the patient has pretty much settled and walking freely. So you could have just assessed patellofemoral symptoms a little bit more in detail in terms of stair climbing,
Yes, sir.
standing from sitting position for both groups or something like that. You could have used
Okay, sir.
measures of patellofemoral arthroplasty and intermingle that into your resection technique study, and you could have a much more glamorous outcome of your study as compared to just grinding or
Yes, sir.
anterior knee pain, because anterior knee pain at the end of the day is kind of a subjective thing. It could be as a result of in some patient medial arthritis, and in some patient lateral arthritis, and in some patient just because of stiffness. So those are the few points that you could have included in your study and made it more meaningful in terms of outcome. So these are the strengths and the weaknesses of your study. If anyone else has a question regarding the study itself, I think we could welcome them first, and then we can conclude by discussing a little bit about patellar resection technique anyway.
There is some
Yes,
questions.
that's a good idea. Let's
there are some questions.
unmute Dr. Yasser, who's asking this question in the chat box. So can we have Dr. Yasser here?
Yes,
yes,
I just
please.
unmuted him.
जी, assalamualaikum.
Dr. Yasser, क्या हाल है? ठीक हैं?
Alhamdulillah, Ahmed, nice work done. I may say, although I think Mujahid answered me that you did mention the number of knees operated. I thought you only mentioned the number of patients operated. So how many knees were there?
Sorry, sir.
I will tell you.
114.
Dr. Yasser is asking about the total number of knees
Yes,
operated,
sir.
as well as the knees operated with freehand and the patellar guide technique.
Sir, total 114 knees were operated. 57 were with freehand technique and 57 were with patellar resection technique.
Okay. Thank you.
Okay, so we have another hand raised. It's Dr. Uzair. So can we take him on board here?
Yes, sure. I think in name of Dr. Imran Haider is there.
Assalamu alaikum.
Assalamu alaikum. Ji, Dr. Kasrani.
Walaikum assalam. I am Dr. Imran Haider Kasrani from Multan, Nishtar Hospital. I have a comment first before I ask a question. Professor Muhammad Umar is also one of my mentors, and he does it by freehand, and he is master at what he does. The problems with the freehand technique is that if it is being done by a new surgeon who is not very expert and apt in doing such things, it can be disastrous, because if you do not have very good control over the saw which you are holding, and the assistant who is holding the patella, if he isn't holding it squarely, one can sort of sink in the saw at angles which can give one issues. Likewise, even if one is using the patellar jig can be tricky as well, because of the tension from the lateral structures, and we have everted the patella. Once we apply the jig, when the saw hits the patella tends to tilt. And if we keep on cutting it down without basically adding the freehand technique to the jig technique, the results still can be very bad, because we can have a patella that can have a very thick medial surface and a slanting down thin lateral surface, which will obviously give issues with the patellar tilt, as well as will give a radiological problems with subluxation and slightly tilted patella. So in my opinion, for the new surgeons, it has to be a combination of the freehand technique as well as the jigs. While applying jig, one has to make sure that the patella is sitting squarely in the jig, and then keep palpating it repeatedly to make sure that the thickness is uniform when we measure it from superior to inferior aspect, as well as from medial to the lateral aspect. We cannot simply rely on any one technique to get excellent results. Even after the application of the jig, even with the serrated jigs who tend to hold on to the patella still tends to tilt slightly. As Dr. Ahmed Jamal mentioned, he said that he sort of holds the nose of the patella with the finger underneath. Similar sort of metal bars are available with the patellar jigs that are with Johnson & Johnson, and probably with Zimmer as well. He mentioned he did Zimmer. All right. The question that I have is that for freehand technique, before starting with the patellar cut, did you measure the thickness of the patella with the caliper, or was it totally jigless? Was it totally implantless? And once having finished with the patellar cut, did you measure the thickness of the cut which you have cut? Because if such cuts are not measured and everything is kept just to eyeballing, one can easily overstuff the patella or understuff it, which can later cause knee pain and problems with the patellar grind and patellar glide test. Thank you very much.
We measured the thickness of the patella before the cut. Like we measured them with a vernier caliper, and we try to not overstuff or like sort of understuff the final patellar implant with the patella. So these were measured actually with a 1-year caliper.
Right, very right. I have another question. We have a very senior doctor with us, Dr. Azmat Rasool Sahab. He's asking, do you denervate the patella by either technique, or once you're resurfacing, then you don't denervate? What's your routine?
Sorry, can you repeat that? It was breaking, the voice was breaking in fact.
As you rightly mentioned that there are two ways of dealing with patella. One is sort of patelloplasty or
Yes.
sort of denervating the patella and leaving it as such, taking off the osteophytes. The other technique is patellar resurfacing, in which you sort of replace the patellar button. Once we are replacing the button, then technically there is no need to denervate the patella, because you have sort of replaced the articular surface as a whole. So what is your routine and the routine of your mentor? Do you denervate the patella while resurfacing it?
Yeah, sir, definitely, Professor Umar Saab definitely denervates the patella. And the reason being that it may lead to post-operative patellar pain, like it may lead to some sort of pain, and that's why he always denervates the patella. The synovium is removed all around and the patellar denervation is done.
All right, thank you very much.
Okay, so this is all for the questions. If we have further, we will ask the person. So we move to Dr. Mujahid Jameel, who wants to add further to the techniques.
So I'm really glad that we are getting in the intensity of the discussion and getting on top of the patella during total knee arthroplasty. I would say that, the main challenge in cutting the patella is that it is a funny little bone which keeps on slipping from your hands, even if you try to do it freehand or you have the best jig available in town in your hand. So that's one of the challenge that we do, and that's why one of our colleagues was asking, how do you hold the patella? You metal clamp from Zimmer and metal clamp from that company. So yes, I would bias a little bit towards his suggestion that young surgeons who are doing total knee arthroplasty should not be excited by either one of the technique in its own, because patella has been a long standing problem in total knee arthroplasty. If you read articles about total knee arthroplasty and read the problems after total knee arthroplasty, I think 60 to 80% of the problems relate to patella somehow. Even if you replace it, even if you don't replace it, and then when you replace it, how you replace it, what are the problems? So it's a very so the area which has been problematic should be invaded with extreme caution. It should not be taken easily. So that's one message. The other message is about denervation. So denervation definitely has in the literature some benefit in the initial 3 to 6 months post-operative pain relief. Eventually the outcomes are similar, but I would say that even if the patient has a short-term benefit from a little exercise that does not take more than 15 minutes from an average arthroplasty surgeon, it should probably be performed, or every attempt should be made to carefully perform denervation, because it has an inherent benefit of some pain relief in the short term, and it does not correlate to any adverse outcome scientifically. So denervation is a good technique to do. Now, what I wanted to do is to have a brief summary of how the patella should be resected, so that our surgeons and I myself can remind myself as to what is the good technique to do it. I will start with the presenter again. So I will ask him, what are the aims? What is the eventual aim of resecting? If you are resecting patella, what is the aim of resection? What is the main aim?
So the main
aim,
yes, sir. I said that it must be the resection must be a symmetric one, so that we may not encounter problem afterwards, and the patellar thickness must be restored. Sir, yes, sir. We can achieve symmetric thickness.
Symmetry को कैसे guide करते हैं? How do you target your symmetry?
Sir, if it is parallel to the anterior surface of the patella, and so that's what.
Do you know where is the geometric center of patella? Geometric center means, you know, when we talk about hip replacement, we talk about the center of hip rotation. Yeah.
Yes, sir. Yes, sir.
So in the same
Yes.
way, the patella is moving around its geometric center. So do you know where it is located?
So around the nose, maybe, but I'm not sure about it.
So when you invert the patella, where is
Yes,
the
sir.
geometric center? So you have done the knee replacement and you are now targeting patellar resection, and you invert the patella for cutting the patella, right? So where is the geometric center?
Geometric
Any
center.
idea
So
about
around the
medial and
nose,
lateral
maybe around the nose of the
nose?
patella.
What is the nose? So geometric center of the patella is a little bit medial to the ridge of the patella, right? So it's not
Okay.
exactly where the medial and lateral facets are meeting.
Okay, sir.
Okay, so that's one fact. What is the other fact? What are the other things that you should be cautious of to make a, you are right, you said symmetric resection. But what are the pitfalls in doing a symmetric resection? One is geometric center. If you're not clear about where is the geometric center of rotation, then you can always be misled by how you cut the patella. Second fact is the lateral and the medial facets are not equal. Not only unequal in medial, lateral, anterior, posterior dimensions, but also not equal in terms of the cartilage thickness.
Okay. Yes, sir.
Right? So the
Yes,
most
sir,
common
right.
error, what is the most common error done in asymmetric resection? When you say asymmetric resection, you should be aware of what is the most common error.
Sir, like lateral side is a bit thinned out.
Lateral side is thick, not thin.
No, if we cut it asymmetrically.
Okay, that's fine. That's fine. We are not in an FCPS exam. I'm just trying to sort of intensify your
Yes, sir.
thought
Yes, sir.
process so that you have made an effort and you learn something. So what happens is because lateral facet is thicker, number one, and because lateral facet is less loaded, so the bone is easy to cut. And what we most of the time can end up doing is cutting more of the lateral facet as compared to less of the medial facet.
Yes, sir.
So if you cut more of the lateral facet, you end up in what you were saying is asymmetric resection. And when you
Yes,
have
sir.
done an asymmetric resection, then you end up having problems.
Yes, sir. Sorry, I meant actually that lateral surface is thinned out if it's cut asymmetrically, like I wanted. Okay, sir. I wanted just
Good.
that it's a bit more cut and it relatively thins out as it should not have been. Like it must be thicker and it's thinned out, in fact.
Okay, so that's one point. The other point is before starting resecting the patella, before starting
Yes, sir.
resecting the patella, you should always do the range of motion test once you
Okay.
have completed the rest of the knee. So you have done the patellar component resection and replacement, you have done the tibial component resection and replacement, and you are trialing the knee. So
Yes,
while
sir.
you are trialing the knee for other medial lateral balancing, varus valgus and all that, before cutting the patella, you should invert the patella again and see if it is subluxing. So if it is
Yes, sir.
subluxing before you resect, you should correct all the factors before you resect the patella rather than resecting the patella and then getting to know it is subluxing, because it could be subluxing because of something else and you are thinking of an asymmetrical cut of the patella, right?
Yes, sir. Right. Very right.
So once you have resected and completed femoral cuts, once you have resected and completed tibial cuts, and once you are putting the trial implants, I suggest and strongly recommend that you assess your patellar subluxation and seating during dynamic range of motion testing before you start resecting the patella, so that if there is anything wrong related to something else, you should correct that one first before you start to cut patella and you are thinking that you have cut the patella wrong and that's why it is subluxing or tilting. So those are the few points that you should remember.
Yes, sir. Definitely.
We have another question from Dr. Akant. So let's invite him here. And he has to, actually he wants, Dr. Akant.
Hi, hello,
Yes.
Dr. Akkad.
Assalamualaikum, Dr. Akkad.
It was a nice presentation and really good for knowledge. My question is that what is the advantage of freehand or cutting edge? Is it a time-saving procedure or just we are comparing the two techniques?
We are comparing the two techniques basically, not a great time-saving procedure because Patellar resurfacing does not take a lot of time. So it's not basically a time-saving procedure. These are basically two different techniques of doing the same thing. So we are just comparing which results are better.
So the recommendation for this technique, the expert can go for freehand rather than the new surgeons.
Yeah, definitely. What's said actually.
Okay, thank you.
Thank you.
Okay, thank you very much. So I had a few questions regarding the study methodology. Of course, I'm a pediatric orthopedic surgeon, so most of the technical conversation here was quite alien to me. So you conducted an RCT, which of course generates the highest form of evidence. So my question is that if you have an RCT, usually it is recommended that we do before starting the study, we do a trial registration. Did you go for anything like that?
Madam, a trial registration basically?
Because, for example, if you want to, yeah, the International Council for Journals of Medical Editors, ICJME, they offer this service. They register your trial for free, but like in return, you have to put in your data over there. The whole idea behind registering your trial ahead of time on a website is that you are making it transparent. Because in our city, there is a lot of ethical concern that there is no harm being done, especially if we have a clinically based study.
No, madam. In fact, we did not go for that.
But like for future references, if you want to do an RCT, because of course it takes a lot of effort and it's a very kind of time-consuming and resource-consuming kind of a study design. So it's advisable that you do that. Second thing concern was you didn't mention if there was an ethical committee approval.
Oh, yeah, madam, there was an ethical committee approval. Maybe if I have forbid, I thought I have, but you're right. I may not
It was
have.
definitely
Yeah, but we
it is
definitely
obvious.
seek approval for ethical review committee.
Okay, and like you yourself mentioned that one of the limitations was that you couldn't assess the functional outcomes.
Yes,
so
ma'am.
generally, if we have the functional outcomes, especially because when we determine functional outcomes for any procedure, we do either patient-based or clinician-based. And these days, it is always preferred that we have some patient-based functional outcome score in our studies. It gives your study more power and more authenticity. So generally it is advisable, because since you're putting in so much effort, so bringing in an additional score will definitely help you power your study. And I was also interested in knowing that what kind of a statistical test you applied to get your p-value, because there was a lot of discussion by you about the p-value.
Yes,
so what was your statistical tests?
Madam, chi-square test was applied basically
Yeah,
for
exactly.
the p-value, but
Since you were dealing with categorical variables, mostly you were dealing with clinical and radiological outcomes, which is in terms of yes and no. So that is fair enough. So thank you very much. If somebody has any further things to add, they are free to to ask here. We still have few minutes left.
Madam, actually, I also wanted to thank the Pakistan Orthopedic Association and the JPOA basically for inviting me for such a healthy and academic activity. And especially, I would also like to thank my mentor, Professor Umar Saab is not here. In fact, he was busy, but he has contributed a lot towards his fellows, and not just theoretically, but practically as well. So thanks to both of you.
Okay, so I think we have this last question from Dr. Aftab Elam. If we can unmute him and take his comment or question.
Please go ahead, Dr. Aftab.
Assalamualaikum.
Ji, Assalamualaikum.
Welcome from Hyderabad. Good to see you both, Dr. Aisha and Mujahid. My question is not related to methodology of the surgery. My question is this: what is the role of physiotherapy in before the surgery, and what is the physiotherapy help in the outcome of the good outcome of the surgery?
Okay, thank you very much. So let's go to Dr. Mujahid, I believe.
Dr. Aisha, can you repeat his question?
The question was that Dr. Aftab was interested in knowing if physiotherapy has any role pre-operatively in improving outcomes after either of the technique.
Dr. Aftab, thank you very much for joining us. I hope that the weather is as pleasant in Hyderabad as in Karachi at the moment, but Aisha is just holding us on into this journal club for the last 1 hour. So I have to blame her for a few minutes. It's lovely out here. I don't know how the weather is in Multan. But
Sir,
anyway,
it's hot basically. It's warm.
Huh?
It's hot here.
Come to
The
Karachi.
weather is not so pleasant here.
Come to Karachi, have another 1 year of fellowship. Anyway, so yes, physiotherapy has got a definite role of in pre and post operative outcome. And you know, in best centers in the world, and up to a certain extent, in my practice, I believe in preconditioning. So pre-total knee arthroplasty physiotherapy. So that helps a lot in the sense that the patient would get to know what he or she has to do after a painful procedure. Total knee arthroplasty is a very painful and brutal procedure in all honesty. You know, when you take into account patient perceptions, it's a very aggressive procedure. You are cutting the bones all along, you're adjusting the soft tissues and changing the balance of the soft tissues, which has been there for quite some time. So when you educate your patient pre-operatively as to what would be the post-operative outcome and how would be the initial 2 to 4 months of the procedure, it helps a lot in matching up their mentality and easing off their symptoms psychologically after surgery. So yes, there's not much done in this part of the world regarding pre-operative physiotherapy, but I would invite all of you to think about it for better outcome of your patient and therefore a better perspective in your practice. Post-operative physiotherapy again is very important. And I think direct involvement of the surgeon himself would help because most of the physiotherapists have got a set criteria in their head. Okay, itna सीधा करो, इतना मोड़ क्यों नहीं रहे हो, ऐसे करो, वैसे करो. I've seen it again and again with a number of physiotherapists, even at you know, a very decent institute like Aga Khan, because they don't have an idea as to how aggressive is the surgery. What can you know, an elderly female or male, a granddad or a grandma having a painful procedure, and this young boy who has got limited knowledge, or the young girl who has the limited knowledge of physiotherapy, are just forcing them down to bend their knee and straight it up, whatever the circumstances are. So I think yes, direct involvement of the surgeon himself in the whole process is crucially important, so that they can set target and goals on a daily basis or a weekly basis to have a better outcome of total knee arthroplasty.
Okay, so I had another question from Dr. Mujahid from the patient's perspective. So is there a minimum BMI where, you know, like after that, you don't really recommend a total knee arthroplasty in a patient?
I think it's more to do with patient psychology and assessment of the patient and medical problems rather than the BMI itself. Yes, obese patients would struggle a little more. They would have more operative risk as compared to a non-obese patient, especially if you have a BMI of more than 35. The NHS Scotland has a clear-cut threshold of BMI of more than 35, not for surgery, unless there is a very strong reason. And when I was in Scotland, we would have to have a special approval for having total knee arthroplasty in a patient with BMI of more than 35. And the main reason is the risk of infection and the post-operative physiotherapy and rehabilitation. You know, when you have knee replacement and you are relatively thin and non-obese, you'll still struggle to stand up from the chair. So you can imagine if somebody is obese, how difficult for him or her would be to stand up from sitting position and walk with a BMI of more than 35. So I think clarifying the patient expectations is what is most important, and that's where we lack in our part of the world. We just put it very bluntly that pain will be off and you will be walking and everything will be good. You know, in international literature, there is residual pain after total knee arthroplasty in best centers and best hands. In 90% of the 10% of the patients will still end up having some pain. So one is clarifying the goals. And patients usually think that once you replace the knee, you are up about and walking and everything will be a magic thing. No, it's not like that. So I think sitting with the patient pre-operatively, explanation in detail as to what the operation entails and how the outcome could be, and then judging the patient expectation and actually motivation to have a knee replacement surgery is the most important factor rather than BMI on its own. Yes, BMI as a single factor is important to consider, but as a part of the package, that is what is most important.
Okay, so thank you very much. And with this, we reach the end of our time. And I would really like to thank both our very energetic young author, Dr. Very few authors in Pakistan actually go ahead and conduct an RCT because it's a lot of pain and a lot of effort. So many congratulations to you and thank you very much for sparing your time and sharing your good original research with us. And of course, Dr. Mujahid Jameel for his very fruitful effort and interactive question answer dealing with the audience and with Dr. Ahmed Jamal. So with this, we end the session and we were live on Facebook. So if your friends or colleagues couldn't attend the live session, they can actually go back and look for this virtual journal club on the JPOA Facebook page. So thank you very much, and inshallah we will see you.
Thank you, Dr. Mujahid and Madam. Thank you so much.
Thank you.
Thank you.
Okay.
Thank you, sir. Thank you, Madam. Allah Hafiz.
Allah Hafiz.